Dr. Antoine Roux from the Foch Hospital to introduce us the DigiLut challenge. He's a pneumologist and lung transplantation department at the hospital of Foch in Saint-Rémy. Thank you very much for this information. Thank you for the support of Health Data Hub and the BPI, French Investment Bank. This is a major project for lung transplantation activities. Let me explain to you why. I work at the Foch Hospital. I'm focusing particularly on clinical activities and research work in lung transplants. I'm part of a number of learned societies, like the European Transplantation Society, the Morph Society for Transplants, and the French Transplant Society, and the International Lung and Cardiac Transplant Society. I'm going to try and explain to you the issues around diagnosing rejection and how data science related to the imaging that we've got could play a role in meeting this challenge. Lung transplantation is the only possible curative treatment for some end-stage respiratory diseases in selected patients. There are around 3,000 lung failures in France, and we only carry out about 400 transplants. We take out 2 lungs which are not working, incompatible with long-term health, and we replace them with 2 functional lungs. There's around 4,000 lung transplants per year around the world, and there's 400 in France. The key indications that cover about 80% of cases are COPD, pulmonary fibrosis, and cystic fibrosis. These 3 illnesses cover about 80% plus another 20% of other cases would all have a very high mortality rate if there wasn't transplantation. So that's why we offer transplants to these certain ones, to these patients. The main determining factor for the survival of lung transplant patients is the occurrence or otherwise of organ rejection. So on the survival graphs, we can see that there's been significant progress since the start of the program in 1998. The survival rates have increased, but there is a very significant issue in the initial stages. There was initial loss of life here, but we have changed the shape of the curve. The main cause of this mortality is organ rejection, transplant rejection, which is understood as a heterogeneous process, but the key cause is cellular rejection, which in histological terms it is identified through A-type lesions, which are graded from a scale from 0 to 4. So the key issue is to early diagnosis of rejection in order to treat the patient to prevent this rejection. So we do have a real issue, which is the reproducibility of the diagnosis of these type A lesions. Here's a study that came out in 2016 where international experts had compared their readings on just a few hundred slides. Even in the hands of experts, the reproducibility rate is 0.4. That's actually quite a disastrously low figure. If you had the same thing in radiologists who were diagnosing pulmonary embolism, they would be they would probably be all in prison. So there's real room for progress in this area by using image recognition technologies through digital diagnosis, and that's what we're suggesting in this DigiLut challenge. We are encouraging competitors to improve the detectability and diagnosis of this improve the reproducibility of the observations. There are many stages. First of all, you're going to need to choose a selection of slides out of the 4,000 transplants that takes place over the year in the world. Select 2,000 slides that are annotated over a fairly homogeneous time period. Once you've chosen these 2,000 slides, they will be scanned into digital format. We're going to get a panel of international experts to annotate these images. We're putting together this panel right now. It should bring together a number of pathologists from around the world, and the tool that we're going to be used will allow them to remotely annotate the slides using these scanned biopsies. The target date for the next next stage is the actual data challenge, which we're targeting for May 2023. We're going to put together we're going to make 4 data sets available. Sorry, 3 data sets: an exploratory data set, a test data set, and an experimental data set. We're going to have some normal biopsies. We're still discussing this a little bit with our data scientists at the moment, and the data challenge will take place over a 2 or 3 month period, aiming to improve the identification of these lesions which seem to be compatible with cellular rejection. The end goal is therefore to improve the diagnosis and therapy and the final outcome for lung transplant patients. I think I was quite brief and succinct, but I would be very happy to answer your questions. From having worked with data scientists before, I'm sure that the power of this community may enable us to really move these health care issues forward. This is the type of situation where your input is really going to be vital to us. Thank you very much, Antoine. If there are any questions from people in the room, please raise your hand and we can send a microphone round if necessary. Yes, we do have a question. Thank you very much for this very interesting project. Beyond the black box project using deep learning, do you have any idea why the reproducibility is so low, this level of reproducibility? Any theories as to why that might be the case? Are there any theories that I can put forward in front of an audience where pathologists are present? I can't really say no. I can't. Yes, for these pathologies which are polymorphic on samples which have very variable structures, the inter-observer reproducibility, whether they're different lesions or rejections or other lesions, we get figures of around 0.4 to 0.6. There's an additional bias around sampling. In this case, we're going to work only with samples from the Foch Hospital, where we can take 8 to 12 samples all on glass slides. That's not the case between all hospitals. Between different centers, there can be that bias that operates. One of the things is that there are 400 patients that receive transplants per year. We're quite a large center. There are other centers that are smaller which have a different documentation strategy. They see different numbers of biopsies, so they have perhaps a longer learning curve. But this coefficient of 0.4 through people who claim to be experts. But that is a real problem. definitely. We have another question here. In this type of pathology, the lesions that we see are a continuous range. It's not a black or white question, it's a grayscale question, and these lesions are quite complex. I'm not an expert in pulmonology, but it's very difficult to say a yes or a no about it. So I think this will be very difficult to have criteria that's very reproducible. As you were saying, there's a difference between different samples and the different areas of a sample, and this can give different results from one pathology to another. But the question is about this scoring system. You might find poor levels of reproducibility as well. Well, yes, the ambition that we have with our people who are annotating the samples is to have the slide annotated by at least 2 people. We try to analyze the agreement in terms of these A-type lesions. So this information will be included with our annotation. We'll then have it proofed or checked by a third person if there was disagreement. So we're not going to be a label on the slide, but there's a description of the pathological area and the annotations. So we're hoping that they will agree, and we're going to be quite strict about what we ask in terms of that level of agreement. Got another question here. Thank you very much. My name is Pierre-Antoine Gros. I'm from a medium-sized lung transplant centre. In your strategy, is there any way that we could enrich the diversity in the learning samples in order to reduce the risks of over-adjustment? Would we not gain by including various different centres in the biopsies? With regards to the idea of working with other centres and to enrich the evaluation data set with data from other centres, we are looking at that. We're working on that. That's a possibility. The first issue is going to be around formats and then the numbers of biopsies that are available. But this is going to be I suppose what you're talking about is injecting a bit of real life into the data set, and that could be interesting. In objective terms, we're not entirely there, but that's one of the options that we're thinking about. The first obstacle would be the format, actually.